Hello everyone, and welcome to the third ECMM Healthbook live webinar on fungal infections in the ICU. So my name is Martin Hoenigl. I'm the current president of the ECMM and associate professor for translational mycology at the Medical University of Graz. And I will guide you today through the program with my co-chair, Professor Volkan Özenci from Sweden, from Karolinska Institute in Stockholm, Sweden. So as you can imagine with my co-chair, our virtual webinar today is placed in Scandinavia, and I'm very happy that we have a very exciting speaker panel. Let me just try to forward my slides here. So speakers will include Jannik Helweg-Larsen and Ingvild Nordøy. Jannik is from Copenhagen, Denmark, and Ingvild is from the University Hospital Oslo in Norway, and they will both present very interesting cases outlining the problems in clinical management, in diagnosis of fungal infections in the ICU. Then we'll head over to Simon Feys, who is a PhD student and internal medicine trainee at UC Leuven in Belgium. And he has really had some groundbreaking findings in terms of fungal immunology and specifically immunology of COVID-associated pulmonary aspergillosis. So he will present a translational talk, talking a little bit about the risk factors of the host and the immunological mechanisms that predispose us to invasive fungal disease. And then we will head over to Professor Krause, from head of the division, or head of my division from the Medical University of Graz as well, who will talk about the clinical implications of invasive fungal infections in the ICU, particularly, of course, focusing also on treatment. And with that, I think I definitely want to thank the ECMM and also Healthbook for organizing this webinar, and also to Gilead Sciences and further co-sponsors for sponsoring this webinar series. And I want to encourage you to ask questions at any time via the online app. So you can, via the online app or web page, you can ask your questions, and we will discuss the questions after each of the talks. If there are still questions open, we may also postpone basically the discussion to some email responses from the speakers. And with that, I'm very happy to hand over to my co-chair, Professor Volkan Özenci from Karolinska Institute, to introduce the first speaker.
Welcome, everyone. We have two distinguished speakers soon who will present the case presentations from Scandinavia. Our first speaker is Dr. Jannik Helweg-Larsen, and Dr. Helweg-Larsen is currently a senior consultant in Department of Infectious Diseases in Rigshospitalet, Copenhagen, Denmark. He is also a clinical assessor in the Danish Medicines Agency. His primary interests fields are invasive fungal infections, pneumocystis pneumonia, and other opportunistic infections. Dr. Helweg-Larsen is the Vice President of Nordic Society for Medical Mycology as well. Please, Jannik.
Yes, I'm very pleased to be able to present this case. I'm a senior consultant at Rigshospitalet in Copenhagen, and my case story is actually on a patient we have hospitalized right now at this department. So this case is about a 60-year-old male who was admitted several weeks ago with severe sepsis and meningitis. Apart from dysregulated IgDM, he's healthy. He was quite sick when he got here. He had a DCS of 8, and it was a classical case of Staphylococcus aureus, septicemia with Staph aureus in his blood cultures and his CSF. He has no endocarditis. We did a CT, and he has multiple cavitary infiltrates, but no abdominal pathology. He was treated in the beginning with meropenem and dexamethasone. Dexamethasone was because of the bacterial meningitis until we got the pathogen. And he's currently been treated with high-dose cefuroxime, which has some improved CNS penetration compared to cloxacillin. So at day 2 and 3 at the ICU, he was improving and the CRP was decreasing. And actually, after 4 days, we were able to extubate him. He had a wake-up call and he was stable. But at this time, the CRP was increasing, and we do quite often routine cultures, and we found that he had Candida albicans and Candida glabrata in his tracheal secretion, as well as yeast in his gastric secretion. So now the question to the audience is, and just pause a bit, would you at this point initiate the empiric antifungal treatment? The patient is stable, his CRP is increasing, which we found that he is colonized with yeast. And if, which antifungal treatment would you apply? So the next day, we actually find that this patient actually got candidemia, and it's reported to us that he has yeast in two blood cultures taken from the CV from his central venous catheter, but his peripheral blood cultures are negative. And at this point, Casper Fountain was initiated. His CVK was removed, and we repeated the echocardiography, which was normal without sign of endocarditis. And next day, we get the full results. He has a Candida glabrata candidemia in the blood cultures. Now this gentleman, 2 days later, he is persistent febrile and his CRP is stationary high. And at this point, would you change the treatment or would you do other tests? Obviously, we do work off for other infection, and we identified that he has a pleural empyema was evacuated linked to his Staphylococcus septicemia. And the source of his Staphylococcus was actually a spondylodiscitis with epidural abscess. But at this point, at day 9, the patient suddenly complains of unclear vision on his right eye. And a fundoscopy was done, and he had fluffy infiltrates compatible with fungal endophthalmitis. And you see some pictures here from the fundoscopy, and you see the atypical signs of what we see in fungal endophthalmitis. So at day 9, he is receiving caspofungin, and the question is now, would you change the antifungal treatment? So obviously, echinocandins has very poor CNS penetration as well as vitreous penetration. So echinocandins should not be used for CNS or severe eye infections. So the patient was changed to ambisome, and we also administered intravitreal ambisome twice. And the next question is, how long would you actually treat Candida glabrata, fungemia, and endophthalmitis? The patient is stable, and we've been following him during ambisome treatment, and after 3 weeks of treatment, he has no activity in his endophthalmitis. But at this point, would you continue the treatment? We elected to continue the ambisome. The usual guidelines is that you have to treat at least for 4 to 6 weeks. And when we did follow-up fundoscopy here last week, we actually found that he had some progression of his fungal infiltrates. And we have now repeated intravitreal ambisome, and we are still following him. So we are extending the ambisome treatment. So just to summarize some of the some points from this case, it's actually a bit unusual early in presentation. This gentleman had no abdominal sepsis. As you know, the majority of patients with invasive candidiasis has usually been hospitalized in the ICU for more than 3 to 4 days. Overall, we managed this patient as we usually do. We treat early with echinocandin, and we treat usually 2 weeks after the last positive culture, and we try to de-escalate to azoles if possible. The main problem is obviously that this patient has Candida glabrata candidemia, and all Candida glabrata candidemia species, at least in Denmark, are azole resistant. So we are obliged to continue with echinocandins or ambisome in these cases. And this is actually a problem in Denmark because at the moment, 40% of our fungemia are caused by Candida glabrata. The other key points of management of invasive candidiasis is that you have to remove all foreign devices which may be infected. TE is also recommended, although endocarditis is very rare. And the next question is, should we actually do fundoscopy in all cases of fungemia? So with that, I will leave it open for discussion and questions.
Thank you so much for a fantastic case presentation, Jannik. So there are a few questions actually in the chat, and I will just start with the first one. So how would you explain the change in CRP from days 2 to 3 to days 4 to 5? I mean, it's an unspecific marker, so not an easy question to answer. But...
Yeah. Obviously, it's not. It might not be the case that is the candidemia which is causing the CRP increases. Might as well be the Staphylococcus infection. Obviously, the patient had pleural empyema, and we certainly know from Staphylococcus septicemia that you might have prolonged CRP elevation and fever, but was quite surprising actually that this patient had a candidemia, and you could question if you find Candida glabrata only in the CV in central venous axis and not in the peripheral blood. Is this a true invasive fungemia? But I actually think with the endophthalmitis, we're quite sure that it's a case of invasive candidiasis. The other possibility would obviously be that he had a bacterial endophthalmitis, but our eye surgeon thinks that it's most likely fungal endophthalmitis. So it's quite unusual actually.
Fantastic. So I just want to add kind of like, because this is also something we conducted from the ECMM, this multi-center European study with 60 participating centers reporting their first 10 cases of candidemia occurring after July 2018. And also there we found, I mean, it's always confounded because not all patients get a DEE or a TTE or a fundoscopy, right? But among those patients who get this examinations, about 10% each had either endocarditis or some eye involvement. So I think it's a relevant complication. We of course don't know how often it occurs in those patients where we don't do, for example, a fundoscopy, but it's still a relevant complication, a subset. And there's always the discussion, if this really endophthalmitis or is it just a
chorioretinitis. And obviously, if you have a chorioretinitis, the prognosis is much better. But we know that if you're certain that you have endophthalmitis, then your risk of getting decreased visual acuity is almost 50%, and we see a very few patients who loses their sight. So the endophthalmitis are quite serious, and we should actually change the empiric treatment in these cases.
I have also a question about the duration of the treatment. Do you use methods other than blood cultures for diagnosing candidemia or
Yeah,
estimation of the treatment?
we actually do the T2 PCR now and the menin antigen, and we just published a study. I could actually show you some of the slides from we did antifungal stewardship. I just have to show. Because as you know, you can do the several biomarkers available for diagnosing Candida, because it's a main problem is that all the cases with culture negative invasive Candidiasis. We just recently published this study in Journal of Fungi, where we examined antifungal stewardship, which was based on the use of T2 Candida PCR and Candida menin antigen. In Denmark, we don't use beta-2 glucan, which many other centers do. And in this trial, we looked at 219 ICU patients with sepsis and a high risk of invasive Candidiasis, and we diagnosed a total of 36 patients with invasive Candidiasis that is proven or likely. And our approach, which is more or less the approach we still do, is that we screen high-risk patients who are at the ICU with risk factors. The typical risk factors are abdominal sepsis, Candida colonization, prednisolone, and obviously fever of undetermined cause. And in this stewardship program, we screen patients 2 or 3 times a week with blood cultures. And if we got a positive test, and the main advantage of the T2 PCR that you get a very fast tested. In those patients, we start treatment, or in the patients who had negative tests and who were started on empiric treatment, we were able to de-escalate. The performance of these tests are certainly not perfect, but in our trial, we found that the sensitivity of a combination of the T2 Candida and the menin antigen was around 70%, but the positive predictive value was only around 63%, but the negative predictive value was quite high, at least in our patients. And when we used it, it contributed that we were able to, in some patients, to stop the antifungal treatment earlier than we would otherwise have done. So we think actually the negative predictive value, but as in all biomarker studies, we still have a problem with these biomarkers. They are not always clinically working as well as we would like them to do.
Thank you very much.
Yeah.
Jannik, for your excellent presentation. And we move to our next speaker, Dr. Ingvild Nordøy. I'm very happy to introduce Ingvild Nordøy, who is a specialist in both infectious diseases and medical microbiology, and she is the head of the section for clinical immunology and infectious diseases at Oslo University Hospital in Norway. She's particularly interested in diagnosis and treatment of invasive fungal infections. And Dr. Nordøy has been the president of the Nordic Society for Medical Mycology for the last 9 years. She has resigned recently in August and is currently a board member in ECMM. Please, Ingvild.
Thank you, Volkan. Well, without seeing me, I'll just tell you the story. This is a patient we sent to the local hospital just last week. She'd been with us for 3 months. Next slide, please. Now, this is a 68-year-old woman, and she has an epilepsy, still using medication for it. And at 42 years of age, she got the diagnosis systemic lupus erythematosus and had arthritis, skin lesions, leukopenia, and then positive antibody tests. And she's been treated with different medication, but for the last, 5 years at least, she's used prednisolone 5 milligrams daily. And the last 3 months, she's been switched from azathioprine to methotrexate weekly. Now, 35 days before she was admitted to the local hospital, she had problems with her joints, increasing arthritis, eruptions of dermatitis, felt generally ill and started to be confused. She had HCV eruptions on her lips. And then she saw her rheumatologist 18 days before admission, and she increased the prednisolone dose to 20 milligrams daily, and then again to 40 milligrams daily 6 days before admission because she wasn't improving. Next, please. So at the local hospital, they found that she was really confused, cognitive impaired, and her husband said that she had been different from what she'd used to be, maybe the last 6 months. But then she had lost weight, lost her appetite, she was feeling sick. And in Norway, we always have to say in our journals, how many times have the patient been vaccinated against the coronavirus? And if they've had corona, and she had her vaccinations, have not had her disease. On admittance, she was stable. She had no fever, but she was confused. And as you see her blood counts, they were not bad. Some CRP, some liver irritation. She had a low complement levels, not very much, but still. But her antibodies, the anti-DNA antibodies, were negative. And they started with a CT scan of her head that was normal. Next, please. And they did a full investigation. They did the MRI of her brain. They did the CT of column, thorax, abdomen on day 3, and they did an MRI, or not MRI, angiography of her brain on day 11. They did a PET scan on day 17. They did skin biopsies. They did 2 spinal punctures. They did a bone marrow biopsy, and they did an EEG, and examined for infectious agents, and examined for autoimmune encephalitis antibodies, and also took antibodies for the paraneoplastic encephalitis. Clinically, she grew more confused, irritable, increased dyspnea. She got a fever, and she really had a general failure of her condition and got bedridden. And then the cytopenias came in with platelets down to 75, leukocytes down to 1.5. The ferritin levels rose to almost 25,000. LD was 1,500. We also like the soluble IL-2 receptor because we were sniffing at the HLH, the hemophagocytic lymphohistiocytosis here. They did a bone marrow biopsy, but didn't find any hemophagocytosis in the marrow. And the skin biopsy didn't really give much information. While she was there, they saw that she got lung infiltrates, and she got her dyspnea, and that might be, of course, connected. And they wondered whether this was induced by the methotrexate that she had been getting the last 3 months. And on the PET CT scan, they saw uptake in the lungs, in the spleen, and in abdominal lymph nodes. They couldn't really say if this was just reactive or if this was some kind of malignancy. Next, please. So they concluded, could this be an autoimmune encephalitis? Her EEG showed encephalopathy, but there were no pathology on the MR angiography and the CT of her brain, and the CSF turned normal both times. They didn't find anything there. And then this HLH, as we do it short, was coming up. And was this connected to her confusion? Was this all an SLE really going through the roof? So they started her on methylprednisolone. She was given 1 gram for 6 days. And then they had a 6-day stop. And then they started her again on 10 milligrams twice daily. And then on day 19, we were contacted, and she was switched to dexamethasone, 10 milligrams twice daily, which we usually use when we're treating the HLH. Of course, she was treated with antibiotics. They start really nice in Norway with cefotaxime, and then they went off to piptazo after 5 days. Didn't really change much. Next, please. So she was transferred to our hospital, and when she got to us, she was really confused. She was obviously in some pain, and she was had difficulty breathing, not that much, but still, and her oxygen levels were falling. And you see here on the side, she had a CT scan taken on the day she came, and it doesn't look all nice, these pictures. So we didn't really understand what was the reason of her condition. And then you start HLH. Well, in a grown woman of 69 years old, you have to think malignancy first most and start looking for that. But we also knew she had an SLE. But strangely, it didn't seem to be very much very aggressive with no antibodies present. Although her clinic definitely suggested that there had been activation in her rheumatological disease at presentation. And of course, an infection could also bring out this picture. But she was intubated on day 24. She needed some rest. And the day after, we took out her spleen and also an abdominal lymph node. We did a new spinal puncture and performed a bronchial lavage while she was in anesthesia. But only 2 days later, she was extubated. So she wasn't really those heavy ICU patients, but still she was there. So she's a good story anyway. Next, please. Now, on day 25, this was when we performed this the bronchial lavage. And as you can see more clearly, she has lesions that make you think of fungal infection. Most of all, maybe Aspergillosis. Next. Thanks. And then you see we got eventually the message from the lab came ticking in. The first 2 or actually 3 answers we got, but that she actually had pneumocystis, strongly positive DNA, negative. They still do the immunofluorescence here if it's a strongly positive DNA. And we do the DNA for Aspergillus species and also for Aspergillus fumigatus. They were both positive. And one might think, should we start treatment at this point? Certainly for the pneumocystis, but do we treat really only on DNA findings in bowel fluid? Given her pictures, we have the CT pictures. It looks like Aspergillus and should be treated as an Aspergillus. And she was in heavily immunocompromised patients, having received really loads of corticosteroids. On day 31, we got the message that she had Candida albicans in her blood culture, but in only 1 of 4 bottles taken at that time. And that's always a bit tricky. What should we do with that? And on day 33, the growth of Aspergillus came on 5 of 7 dishes, which, well, made us feel better and more certain that this was indeed an Aspergillus infection. But actually, having looked at her CT scan, we were quite certain of that. And then on day 45, we even got growth of Mycobacterium avium from the spleen, not from the ball, not from blood, but from the spleen. In these patients, we do quite a lot of tests, sometimes to frustration about what the answers are, but this was a finding. And then on day 72, she really had a high CMV level and she had deteriorated. So that was the explanation for that. It was a bit under the radar for us for a while, but we got her. So you see that her Aspergillus fumigatus, as most of these species in Norway, are really not resistant at all. We could use any azole, any amphotericin B, even echinocandin if we would like. And you see the Candida albicans is also a smooth thing, no resistance going on there. So we can actually treat how we want to. And if we see how we treated her, of course, we started her on TMS for her pneumocystis. The day we got the answer about that, we thought actually her clinic was very much like it, although the CT scan wasn't that bad. We started her also on isavuconazole on the CT scans and the PCR answer. Because again, she was a heavily immunosuppressed lady there, and of course should be treated. And then we started after a while when we got the Mycobacterium, the MAC answers for that, and that was a problem because when you introduce rifabutin and you have a patient on isavuconazole, it's going to be a clash, and that's mostly. Actually, there's two things. When you start a patient with TMS and isavuconazole, you have to be careful because these patients tend to get arrhythmias. Now, she was under supervision, and TMS is the better pneumocystis treatment that we can give her, and she was not allergic. So we did that under straight supervision. This patient had atrial fibrillation in between, but it worked out all right. But then when the MAC answer came, what about isavuconazole and rifabutin? And there's interactions here that might be problematic. And at that time, we changed the isavuconazole to a needle of fungin because of that. And of course, she got against cyclovir. Next, please. So she had her HLH, fluctuating cytopenias, a bit fluctuating ferritin levels, but they went all the way up to 99,000. But at that time, she had not cytopenias. So we had, as we say in Norway, ice in the stomach, and just watched her, took down her steroids slowly, and she was doing fine actually. And then the last 2 weeks before we transferred her back, she more or less spontaneously dropped her ferritin levels from 99,000 to 22,000. We're still not quite certain what's been triggering her HLH, but we have not been able to find any malignancy on her. And we have not been able to find infections that triggered this. Maybe the MAC infection that we find only in her spleen. That might have been there before she was admitted to her local hospital, but we're not so certain. The other infections are surely a result of her treatment. And then we're stuck with the SLE. Could that actually be the Felden here? The rheumatologists don't really agree with us, but we are not quite certain. Next, please. So we sent her home to her local hospital in improvement. We haven't heard from her or them for a week, so we're crossing fingers and things. I think she will be doing fine. these are some of the points I've already mentioned, actually, what to do when you only find Candida in one blood culture. And when we have a patient in the ICU, we do take blood cultures daily if we suspect, of course, there is infections. If we have had a finding, we continue to take these blood cultures, and that was the only blood culture that came out positive. In her case, with all that corticosteroid treatment, we would have treated it. Usually, we would have chosen the decanocanon, but we were going in with the Aspergillosis treatment and was covering in that way this sort of thin finding of one blood culture positive. Just finding a PCR positive, we have in our hospital with these really ill patients. We started with when we did the influenza 10 years back, when we had the swine and the bird flu. So we have a package we go through when we do the BAL in patients, where they do PCRs for Aspergillus mucoralis, Aspergillus species, and fumigatus. And then, of course, we do cultures for microbes, for bacteria, and also for yeast and mold infections or mold. So that's a package that's really good. And we've taken it out now that we've had the COVID. And we still do it when we have patients with respiratory infections suspected. But only starting treatment on a positive Aspergillus PCR, we don't really do that. We want to have more. We want to have a growth, and we do then take the CT scan to see how it looks. I've already commented on these last two about the interactions and the cardiac problems you might see. Yeah. All right.
Perfect.
That's my case.
So much. Thank you so much, Ingvild, for a spectacular case, highlighting, I think, something we learn more and more, that often there's not only one fungal infection, but sometimes there are two. Whether it is pneumocystis and Aspergillus, so that's also something we've seen in Graz, in an HIV patient. And then we have also Aspergillus and mucorales that often co-occur, and other fungal infections that occur as well. So patient may as well very well also have candidemia. So I think very important case. There are a number of very interesting questions in the chat. But given the advanced time, I would like to ask you, Ingvild, to answer that questions directly in the chat or via the online homepage. And for us to just move on with the program, if that's okay.
Fine, yeah.
Perfect.
Thank you very much, Ingvild.
Fantastic.
Thanks.
So I will basically happily introduce our next speaker today, which is Dr. Simon Feys from UZ Leuven, who is working with Joost Wouters, with Catherine Lacroix, and other big names in clinical mycology there. And he's really a young and rising star. So he's now involved in a number of high quality top papers in clinical mycology that came out over the last year or two. He's also working clinically besides being a PhD student and doing excellent basic mycology research work. And his talk today will be about systems biology in pulmonary aspergillosis, bridging pathophysiology and the clinic, which is exactly what he is doing. So welcome, Simon, and I'm very much looking forward to your talk.
Thank you, Martin, and thank you for the kind introduction. Can you all see my screen?
Yes.
Okay, yes. Perfect. These are my disclosures. I'm going to talk about viral-associated pulmonary aspergillosis specifically. So as you all know, VAPA is constituted by influenza or COVID-19 associated pulmonary aspergillosis, or YAPA and KAPA to make things easy, which are severe superinfections with the fungus Aspergillus in patients admitted typically to ICU with severe influenza or severe COVID-19 pneumonia. And as of now, the pathophysiology still needs to be unraveled, why these patients or a subgroup of these patients admitted with severe viral pneumonia develop aspergillosis, because even patients who are not severely immunocompromised but who are healthy before their ICU admission may develop this aspergillosis, which is quite atypical. And getting to know the pathophysiology better is, of course, a requirement to improve our diagnosis and our therapy for these patients, because, and this is important because both the diagnosis and the therapy are currently very hard. Patients who are treated with antifungals right from the beginning still have a mortality that is near 50%. Before I'm going to talk about our research, I'm going to give you a very short and very basic introduction to our antifungal host response against Aspergillus fumigatus and other Aspergillus species. So each and every day, we all inhale approximately 100 to 1,000 Aspergillus conidia or Aspergillus spores, but our respiratory tract can easily get rid of them using mucociliary clearance. And for the spores that are retained within the lungs, they can be phagocytosed and easily be killed by macrophages in particular, or by neutrophils. But if there's damage to the respiratory tract, the spores are not that easily brushed out by mucociliary clearance, for example, in viral pneumonia. Or if the spores can escape the phagocytosis and the killing process in the phagocytes, then these spores may start to germinate and form hyphae, which may invade the tissue and cause invasive pulmonary aspergillosis. And once there are hyphae, the most important cell to battle these is the neutrophil, and the neutrophil has different techniques to tackle these hyphae, namely reactive oxygen production or formation of neutrophil extracellular traps, NETosis, or by degranulating antimicrobial peptides as such. Now, we want to get a better view of what is happening in VAPA, and why some of these patients with severe viral pneumonia get VAPA. And a very exciting way to do that is via multi-omics. Multi-omics is using very large biological data sets, tackling different aspects of, in this case, immunology. And for example, some examples of omics are the genomics, perhaps the most well-known, transcriptomics, looking at the transcriptome in patients, proteomics, looking at the different proteins that are there, epigenomics, metabolomics, looking at the metabolites, or microbiomics when looking at the microbiome. So that is beyond the host even. And so these multi-omics, when we integrate them together, when we put these pieces together, we get systems biology, in which we try to get a better understanding of the larger picture. So that is actually what we are doing now in our research to VAPA pathophysiology. And as I've said, we hope that by getting to know the pathophysiology better, we will be able to adjust the therapy and to get to better biomarkers. And actually, multi-omics can, even without looking for pathophysiology, be interesting to get biomarkers directly. But I'm going to talk about that more in the second part of my talk. First, I'm going to talk about how we used multi-omics to get to know the pathophysiology better of VAPA, and in particular, we used transcriptomic data and data of a large data set of proteins in patient samples. This was recently published in Lancet Respiratory Medicine. So in our study, we resorted to samples taken from patients and stored in our biobank in patients who had been admitted to ICU, mainly in Leuven in Belgium, during the past decade, because of severe viral pneumonia, because of severe influenza or severe COVID-19. And we went for BAL samples, bronchoalveolar lavage samples, and for tracheobronchial biopsies. And the tracheobronchial biopsies in particular were taken in vivo in patients who had invasive Aspergillus tracheobronchitis. Eventually, we ended up with approximately 170 bowel samples in total, 4 patient groups. We had Yappa patients, influenza-only patients who did not have aspergillosis, Kappa patients, and COVID-19 only patients. And important to say is that these samples were taken generally very early during ICU admission, mostly within 4 or 5 days after they had been admitted to ICU. And the Yappa and Kappa patients were the first available samples of these patients with mycological evidence, positive galactomannan positive culture of invasive aspergillosis. For the biopsy samples, we ended up with 2 samples from 2 Yappa patients and from 2 Kappa patients. We resorted to different techniques on these samples. In the bowel fluid, we went for gene expression of approximately 750 genes using nanostring encounter technology, using a panel with genes linked to innate immunity. For the protein levels, we looked after 47 cytokines, chemokines, and growth factors, also linked to innate immunity. And then for the biopsy samples, we used spatial transcriptomics, and we directly visualized the viral RNA in these samples using RNA-scope technology. I'm first going to talk about our bowel results. This is a volcano plot showing the differentially expressed genes between Yappa patients and versus influenza-only patients. And for those of you who are not very familiar with volcano plots, the x-axis shows us the log2 fold change. So everything on the right side of 0 shows us the genes that are upregulated in Yappa, while everything left from 0, so the negative genes are those that are upregulated or downregulated in Yappa when compared to influenza-only patients. And the y-axis shows us the inverted adjusted p-value. And so we see that this volcano plot is skewed to the left. So that means that a lot of genes linked to innate immunity are actually downregulated in Yappa patients compared to influenza-only patients. And we see some interesting ones like pentraxin-3, MAP1-LC3b, which have important functions in antifungal immunity specifically, and also a lot of genes linked to type 1 and type 2 interferon signaling. And both type 1 and type 2 interferon signaling are important in antifungal immunity and also in antiviral immunity. When looking at a Kappa versus COVID-19 only comparison, we see less genes that are significantly downregulated, but the volcano plot is also heavily skewed, and these genes that we see, almost all of them are also downregulated in the Kappa versus influenza only comparison, and are mostly genes related to type 1 and type 2 interferon signaling. When comparing Yappa versus Kappa and influenza only versus COVID-19 only, we mainly saw downregulation of pro-inflammatory genes. All these genes may be a bit overwhelming, and therefore we performed pathway analysis to see the forest through the trees. And this plot summarizes this pathway analysis. And for Yappa versus influenza only, as expected, we saw downregulation of the type 1 and type 2 interferon response pathways. We saw reduced cellular response to IL-1, and we also saw some effector pathways that were downregulated, such as neutrophil degranulation, monocyte chemotaxis, neutrophil migration. For Kappa versus COVID-19 only, we only saw significant downregulation of type 1 and type 2 interferon signaling. Well, as expected, Yappa versus Kappa and influenza only versus COVID-19 only, we saw a downregulation of pro-inflammatory pathways. The conclusion of this gene expression analysis is that we identified several genes and pathways which are linked to antifungal effector functions that are downregulated in Yappa and in Kappa patients. Using this bowel gene expression data, we could actually infer the fractions of immune cells and of epithelial cells in the bowel fluid. And strikingly, what we saw was that neutrophils had significantly lower fractions in the kappa patients compared to the COVID-19 only patients. And we saw the same trend in the Yappa versus influenza only patients. And this is interesting given the important role neutrophils fulfill in antifungal immunity, especially against hyphae. When looking at the proteins, we looked at 47 proteins, but I'm only going to discuss the main results here. We found that there was a general hyperinflammation as expected. So we found very high levels of pro-inflammatory cytokines, such as TNF-alpha, IL-1 beta, IL-6, or IL-8. But strikingly, these could not discriminate between patients with aspergillosis and those without aspergillosis. When looking at the interferons, we saw significantly lower interferon alpha levels and significantly lower levels of CXCL10, which is an interferon-stimulated protein, in the Yappa patients compared to the influenza-only patients. But for the rest, we didn't really see differences. The most striking result from our protein analysis was the fact that we saw significantly higher concentrations of VEGF, EGF, and PDGF-AA, which are growth factors, and in the aspergillosis patients compared to the non-aspergillosis patients. And this is very interesting given that these growth factors are all related to the development of lung fibrosis. And for example, VEGF also to the development or the severity of ARDS. And so the fact that these are higher in aspergillosis patients may actually potentially contribute to their higher mortality, even despite adequate antifungal therapy. So this is definitely something we should look into in the future. We, of course, integrated this data since we had the gene expression and the protein levels. And what we found was that there was an important local production of most of the cytokines and the chemokines in the BAL fluid. But more interestingly, we found that the response to some of the major cytokines, namely IL-1 beta, TNF-alpha, and type 1 and type 2 interferon, that the response transcriptionally to these cytokines was attenuated in Yappa patients and also in Kappa patients compared to the non-aspergillosis patients. These patients in the bowel fluid, their cells seem not to be able to respond in a proper way to these cytokines. Then for the biopsy samples, we were able to, as my promoter likes to say, to obtain the first family picture of Kappa. So in the 4 samples that we investigated, in one sample we could visualize RNA, and this was in the in this patient that I'm showing now. This was a Kappa patient. So we see a tracheobronchial biopsy sample. And I think on the panel on the left, you can see it the best. You can see the hyphae invading the tissue. In white on the RNA scope image, the DAPI stained hyphae, you can clearly see them invading the tissue throughout the epithelial cells of the host, which are in green. And then in red, you see the SARS-CoV-2 virus or RNA particles of the virus, which is currently or has very recently infected this epithelial layer. And strikingly, in this biopsy, in all places where we could visualize the SARS-CoV-2 RNA, those were the places where the Aspergillus hyphae were invading the tissue. So this strengthens the hypothesis that virus-induced epithelial barrier disruption paves the way for VAPA. We also performed spatial transcriptomics in these 4 samples as a proof of concept. In the inflammatory infiltrate, the immune cells, we didn't really see a difference between the Yappa and Kappa patients at the transcriptional level, but at the epithelial level, we could discriminate the responses to the Aspergillus infection between influenza and COVID-19 patients. For example, in the Yappa patients, there was an upregulation of keratinization as a defense pathway, while in the Kappa patients, we saw an upregulation of, for example, the cilium assembly compared to the Yappa patients. So the conclusions of our first exploratory study are that we could identify certain defects in the gene expression level and also in the protein levels of these YAPA and kappa patients compared to non-Aspergillosis severe viral pneumonia patients. And we identified disturbances in either directly or indirectly in the macrophages, the neutrophils, and the epithelial layer of these patients. So in the future, we definitely want to explore, and we already started with that, other omics in these patients. And also we have now provided some nice hypotheses that can be, or some nice targets for future in-depth studies, such as type 2 interference signaling, as I've mentioned. In these patients, we've seen those lower neutrophil fractions in these patients. This could be due to lower levels of neutrophils, which cause the lower neutrophil fractions, but could also be because of a higher turnover of neutrophils, higher mortality of neutrophils in the lower respiratory tract, for example, because of NETosis. So a lot of interesting ideas to explore in the future. I've talked about pathophysiology now and how multiomics can aid us in unraveling this. But as I've said, multiomics can also be used to as an approach to find novel biomarkers for invasive aspergillosis in the ICU in influenza and COVID-19 patients. And the general dogma or paradigm that we have now in clinic is that we are looking for the rabbit and not for the hunter. So the rabbit in this case is the Aspergillus species. So at the lab level, at the laboratory level, we just look for the fungus. We go for a culture for galactomannan for PCR. To find mycological evidence of invasive aspergillosis, but through multiomics we could also go for host-based biomarkers. So looking at what our immune system does to get a sign of something is going on in these patients. There are several assets to this approach, to mean a total new dimension in the lab workup. Also, given that we have thousands, tens of thousands of possible markers, genes, proteins, microbial species, whatever, there are billions of possibilities if you combine these markers. We might actually, with this approach, be able to identify patients at risk before VAPA has happened from an immunological point of view. And so before VAPA has been able to establish damage in these patients. Also, it could guide immunotherapy indications if in the future we could identify some immunotherapy as adjuvant therapy in VAPA. Also in particular, it might give us a higher chance to find some useful biomarkers in blood. Because as you know, right now the serum galactomannan has low sensitivity to find viral-associated aspergillosis. While if we would look at a host, maybe we can find a good biomarker in the blood. And for me personally, I think this is one of the holy grails in VAPA, which would make the diagnosis much more easy if we could find a good biomarker in blood. Some cons are that there are dynamic shifts in the host immune constituents, so the timing of sampling might be relevant and might shift the immune signature that you may find in these patients. And also noise from other diseases might reduce your specificity, such as underlying diseases, or for example concomitant bacterial pneumonia might shift the immune signature. So those are things to reckon with. And then lastly, VAPA is not your regular IPA if you want to go for biomarkers based on the host. There have been some studies looking for host biomarkers already in IPA, and I think this was one of the first from Samuel Gonçalves from the group of Agostinho Carvalho in 2017, and they looked at IPA and versus control patients, so patients who were suspected of IPA but who did not have aspergillosis, and they found that a lot of cytokines, pro-inflammatory cytokines, were actually could actually serve as biomarkers for invasive aspergillosis. For example, IL-1 beta, IL-6, or IL-8. You see the area and the curves here of the ROC curves, which are quite nice. But when we project that to our patient group, where we compare VAPA patients with severe viral pneumonia patients, we see that these are actually of little discriminatory value. IL-1 beta has an AUC of 58%, for example, IL-6 even of 50%, so no predictive value at all, IL-8 of 55%. So this is, of course, because our background is severe viral pneumonia, and these patients all have very large disturbances in their cytokines. So we should be careful with translating host biomarkers identified in regular IPA populations to the VAPA population. And also, I think that combination of markers will be very important. And as a proof of concept of this approach, we have performed mortality analysis. We have looked for biomarkers for mortality in YAPA patients in the data set that we published in Lancet Respiratory Medicine in the gene expression data set. And what we did was look at the genes that were differentially expressed between patients with YAPA who had died versus those who eventually survived. And we identified 34 genes which had a p-value of less than 0.05 for this comparison. And when we performed lasso regression on these 34 differentially expressed genes, we actually found that 4 of these genes, or the combination of 4 of these genes that are listed here, could actually quite nicely predict mortality in these patients with an AUC of approximately 0.85. And we also tested this in a Cox multivariate regression, confounding for other relevant factors for higher mortality in these patients, such as Apache 2 score, Charlson Comorbidity Index, or older age. And actually, this positive 4 gene score based on these 4 genes could significantly predict YAPA mortality. And this is important. This proof of concept does not only show us a potential biomarker or combination of biomarkers for predicting YAPA mortality. Of course, this needs validation in a separate validation cohort, but it also shows us some insight into the pathophysiology, because the 4 genes that we found were encoding dectin-1, galectin-3, the VEGF receptor, and C4a. And importantly, both dectin-1 and galectin-3 are very important for fungal recognition. For example, dectin-1 SNPs are linked to the development of aspergillosis in certain patient groups. And we found that the downregulation of these 2 genes, so downregulation possibly of fungal recognition, was associated with a higher mortality of these YAPA patients, while a higher expression of FLT1, which encodes the VEGF receptor, was linked with higher mortality. And as I've said before, VEGF the VEGF receptor is linked to more fibrosis, is linked to worse ARDS in patients. So it also provides us some insight into the pathophysiology and what might go wrong in those patients who who eventually die because of their YAPA. As a conclusion, we went over the multiomics and their potential benefits for the VAPA research. And so I think we can conclude that multiomics and systems biology and VAPA hold promise to gain pathophysiological insight, to guide in-depth pathophysiological research, to obtain novel host-centered biomarkers, and lastly, to guide development and the use of, in the future, potentially immunomodulatory therapeutics. For our research that we are currently performing, we will for sure need validation cohorts in the future, because now we have a nice discovery cohort, but sound biomarker finding needs validation cohorts. So we are always willing to collaborate, and if you have samples, please contact us, and we can have a talk. I would like to thank a lot of people, but they could not fit my slide, so I put their affiliations, but maybe 3 people in particular, Professor Joost Wouters, Johan van Wijnberg, and Professor Agostino Carvalho, who have been the co-leads in this research project, in particular in the Lancet Respiratory Medicine paper. Thank you, and I'm happy to take questions.
Thank you so much, Simon, for an outstanding talk. And of course, you can imagine there are a few questions. So just starting off with the first one before handing over to Volkan. Generally, does the different epidemiological transcriptional response to aspergillosis in Yappa versus Kappa cause any symptomatic differences? I mean, obviously, we have to think about, we don't have the clinical evidence, I guess, but it makes still sense that it would cause, right, as you mentioned, with ARDS severity.
I think that's a very good question. I think there are definitely in the epithelial layer, the fact that we see some differences are interesting, but I think honestly that for the difference between Kappa and the Yappa, that the differences will mainly be in the immune cells eventually. In the spatial transcriptomics, we could not really identify this. But this could also be because we had a low N value for these samples. We did this as a proof of concept. But I think in the end, the ability to fight off the hyphae that have become invasive, and it is these invasive hyphae that will mainly drive your mortality. I think that once these hyphae are there and have become invasive, that the immune cells are the most important thing to go for, and the epithelial cells and the fact that these epithelial cells are breached by the hyphae may be important in the very first stages of infection, but in the later stages of infection, which will also drive your mortality, I think the immune cells will be way more important. But yeah, it's nice that we see some differential, some differences between the Yappa and the Kappa patients, and I think like the cilium assembly, which is different, and the keratinization, which is different, are definitely some things that we can look into in the future.
Volkan, do you want to take over the next question?
I just want to ask you about the dynamics of the immune responses you mentioned. How about the differences in the individual groups about time to sampling after admission? Have you checked that? Or were there any differences?
Yeah, we have checked that, and so the median time of sampling was generally very early during ICU admission, within 5 days, but it was a bit earlier in the influenza cohort compared to the COVID-19 cohort. And I think the median day of sampling was 1 day after ICU, 1 day after start of mechanical ventilation, in the influenza patients, and 2 days in the Yappa patients, and I think approximately 4 days in the Kappa and the COVID-19 patients. So there was a bit of a delay in the Kappa and COVID-19 patients, which of course also reflects what happened in most ICUs. I think that bowel sampling was not as easily performed as it was in influenza patients. But that is definitely something to keep in the back of the mind, and we also added it to our limitations of the study. Yeah.
Thank you very much. Is there time for another question?
Yeah, I think we can ask definitely Simon what the status is. I mean, obviously there are grants ongoing and collaborations ongoing and consortium ongoing, but do you have an update about the status of development of immunomodulatory therapeutics against Yappa?
That's a very nice question, and we are currently working with our mouse model, which we have of influenza-associated pulmonary aspergillosis. A colleague of mine is working on that to look for several immunomodulatory therapeutics, and I know that other groups around the world also have Yappa mouse models, so I think that definitely there's some research ongoing over there as well. The problem for kappa as of now is that we don't really have a good model. There's no, to my knowledge, there's no published kappa animal model. And the problem is that in urine models, getting severe COVID-19 is a bit of a problem. And yeah, of course, that's a prerequisite to get nice aspergillosis ongoing in there. But definitely, I think in 1 or 2 years' time, we will have data on some immunomodulatory potential of some agents in the APA model.
Perfect. Thank you so much, Simon, for an outstanding talk. And I think we hand over the program because some of the questions may also relate to some of the content that will be discussed during the next talk by Professor Krause, who is the head of the Division of Infectious Diseases at the Medical University of Graz, and really since 15 years driving, the clinical, but also the research agenda of infectious diseases at this university. He's also a fellow of the ECMM, and it's my great pleasure and very much looking forward to hear your talk, Robert.
Thank you, Martin, for the kind introduction and for inviting me to give this talk. After this very exciting talk given by Dr. Feys regarding the pathophysiology and the multi-omics, I will now focus to clinical aspects of patients at the ICU with fungal infections, and mainly due to viral infections and fungal infections as a secondary infection. So here are my disclosures. What I want to do is to give you a short epidemiology overview of virus-associated fungal infections within the ICU and a clinical overview regarding also treatment aspects of different antifungals in this ICU patients. Let me first start with this slide where we can read that the topic of viral-associated fungal infections was boosted mainly by publications coming from the Netherlands and also from Belgium. Colleagues from several groups showed that viral infections are associated with fungal infections. And the study that boosted this topic at most was the Belgium and Netherlands study from Schoefliege, where 14% of patients with influenza had pulmonary invasive aspergillosis when they were not immunosuppressed, up to 32% when there was immunosuppression present. In the opposite, the rate of invasive aspergillosis was 5% in the control group. But it's not only influenza, as we know, there are also other viral infections that are associated with fungal infections. This was shown by some studies and cases from the US, where parainfluenza and RSV cases were associated with invasive aspergillosis. And then came the COVID-19 pandemic, and we learned that there were at least 3 different entities of viral-associated fungal infections. First, the COVID-19 associated invasive candidiasis, then kappa, COVID-19 associated pulmonary aspergillosis, as you all know, and CAM, COVID-19 associated mucormycosis, mainly rhino-orbital and cerebral in India, but also pulmonary, and pulmonary mainly in the rest of the world. So COVID-19 associated pulmonary aspergillosis was mainly detected during the pandemic in Europe, where most of the studies were done. And we learned in the past that the incidence of COVID-19 associated pulmonary aspergillosis was very broad, starting with 3.8% up to 35% of mechanically ventilated COVID-19 cases. And this was surprising and not good understood when we read these papers and these studies first. So in Switzerland, it was very low, approximately 4%, up to 35% in Belgium. And most of the differences mainly come from local epidemiology, of course, but also from different definitions that were applied to patients with pulmonary aspergillosis in these studies. Then there were also some autopsy studies with different results. In one review, we could learn that the invasive mold disease in patients suffering from COVID-19 was approximately 2%, including 8 kappa cases. But in this review and in the studies covered by this review, the routine fungal staining of lung tissue was approximately 40%, so not 100%. So the investigation was not done in every patient, and only 58% of patients had mechanical ventilation, so not very severely ill. So maybe there was less awareness at this time point, and maybe there was also a lower rate of steroids at this time points, because the studies introducing steroids in the treatment of COVID-19 were published in this time period. So maybe this was also a factor that were accountable to the low rate of COVID-19 associated pulmonary aspergillosis in these studies. A study performed in Italy showed a very high level of proven aspergillosis in COVID-19 associated pulmonary aspergillosis or COVID-19 cases. The colleagues there investigated 45 patients. 67% of all patients had mechanical ventilation, and the routine fungal staining of lung tissue was 100%. And they found proven aspergillosis in 20%, and there was also an increase from one wave to the other wave of the COVID-19 pandemic, and this is maybe the factor that steroids did. So there was an increase from 7% up to 41% in the second wave. However, diagnostic tests performed ante-mortem were only done in 4 of 4 patients. Here you can see fungal infections in France in a retrospective study, and there was an incidence of 50% of kappa patients in COVID-19 pandemic. There were also other patients with fungal infections, candidemia, for example, or invasive mucormycosis, and even invasive fusariosis. And there were cytomegalovirus infections and herpes simplex virus infections. And this is mainly also the driver of fungal infections, mainly candidemia, because of the mucositis that can also be in place in cytomegalovirus infections or reactivation of cytomegalovirus. So what are the risk factors in patients suffering from COVID-19 and at risk for kappa? There are structural and functional lung damage comparable to other viral diseases, and we saw the pathophysiology presented by Dr. Feys previously. There's also the dexamethasone treatment, immune dysregulation associated with RDS and the viral infection. And there's also, beside the steroid treatment, the treatment with interleukin-6 antagonists, and this maybe also drive kappa in COVID-19 patients. Let me now come to the diagnosis of the viral infection-associated pulmonary aspergillosis, and I want to start with influenza-associated pulmonary aspergillosis. There was a consensus in 2020, and in this consensus paper, we have 2 entities, the Aspergillus tracheobronchitis and influenza-associated pulmonary aspergillosis without tracheobronchitis. And when you look at the right side, where influenza-associated pulmonary aspergillosis in patients without tracheobronchitis is mentioned, you can see that there is a pulmonary infiltrate required and at least one of the following: a serum galactomannan of higher than 0.5, or a BR galactomannan higher than 1.0, or a positive BIL culture, or a cavitating infiltrate and a positive sputum culture, for example. We have also a diagnosis guideline for COVID-19 associated pulmonary aspergillosis beside the influenza associated pulmonary aspergillosis. This was also published recently in 2021 by Philip Köhler and others. And we have 3 degrees of infection: the proven, probable, and possible infection, like in hematology patients. And in probable COVID-19 associated pulmonary aspergillosis, there is the requirement of certain host factors, imaging factors, and mycological factors done on samples obtained by bronchoscopy, and there are also clinical criteria that must be present. So this is an example of COVID-19 associated pulmonary aspergillosis, a patient that was treated in our ICU, and you can see the infiltrates on the left picture that are due to the COVID-19 infection, the SARS-CoV-2 infection. On the right side, you can see additional infiltration and the cavitation and the positive lateral flow assay. And these diagnosed COVID-19 associated pulmonary aspergillosis in this case. So let me now come to COVID-19 associated candidiasis. COVID-19 associated candidiasis is not directly related to COVID-19 as we actually know, but it's also present. In a publication in 2021 from UK, we learned that the incidence of fungal infection was 26% of a cohort of 135 patients suffering from COVID-19, and there were 14% aspergillosis cases, but also 12% yeast infections, and the overall mortality was very, very high, 53% in patients with fungal disease and 31% of patients without fungal disease. We also have to be aware of infections during the treatment of such patients. You can see here a patient treated with ECMO, and there's also an ECMO infection by Candida. There are several case reports, so you have to be aware of Candida infections of the ECMO oxygenator, for example. You can see here on the left side these yellowish infiltrations of the ECMO filter and the cultures that were done from the inflow and outflow line. So a very difficult infection, because the change of such an ECMO oxygenator is very, very difficult in such cases. Let me now move on to COVID-19 associated mucormycosis. And as you can see here in this map, most of the cases were detected in India, and there are several reasons for this epidemiology distribution. This started with several cases published from India, and some of the reasons are a high rate of diabetes, but also the corticosteroid treatment as in other COVID-19 patients, but also environmental factors, for example. And it was a terrible situation in India. As you can see here in these pictures, there were certain mucormycosis wards due to the high rate of mucormycosis cases. We also had some mucormycosis cases in our institution, as you can see here in this CT scan, with the destruction of lung tissue, because mucormycosis is a very destructive mode. Is COVID-19 really a factor for the mucormycosis cases? And it is, as you can see here in this publication, where the rate of mucormycosis without COVID-19 were stable in India, but with the COVID-19 pandemic, there was an increase in the overall rate of COVID-19 of mucormycosis, and approximately 50% of all of the cases were attributed in this study to COVID-19. So COVID-19 is clearly a factor that is associated with mucormycosis. Let me now come to the treatment of pulmonary aspergillosis. We have certain guidelines for the treatment of invasive aspergillosis in the hematology setting and in immunosuppressed setting. We can use isavuconazole, voriconazole, or liposomal amphotericin B, and recently also posaconazole with a certain grading, as you can see here in this table. When we look in the most recent guidelines of the ESCMID and ECMM and ERS, we can see that isavuconazole as well as voriconazole has a A1 to A2 grading, and liposomal amphotericin B a B2 grading, and posaconazole is not yet graded, but this will be a topic of the future. For invasive aspergillosis associated with influenza patients, there's also a recommendation in alignment with the recommendations that I showed you previously in the previous slide. The recommendation is that we should use voriconazole or isobuconazole or an echinocandine in combination with anti-mold azoles, maybe in regions where an azole resistance might be present, and liposomal amphotericin B, of course, also in regions with high rates of azole-resistant Aspergillus fumigatus. And it's also necessary to perform TDM, of course, for voriconazole, and it's not clear for isobuconazole or another azole for posaconazole. There are some recommendations, but this is not clear enough to give recommendations. This is a topic for clinical studies. We have also recommendations for COVID-19 associated pulmonary aspergillosis. There are two recommendations for azole-sensitive aspergillosis cases and also for azole-resistant cases. In azole-sensitive cases or in regions where azoles are working very well in Aspergillus, we should use voriconazole or isobuconazole. And as you can see here on the left side of the slide, in voriconazole, it's mandatory to perform therapeutic drug monitoring. And as a second-line treatment, we can use liposomal amphotericin B, and it's necessary to monitor renal functions in liposomal amphotericin B treatment. In case of azole resistance, we should use in proven cases or in suspected cases liposomal amphotericin B or an azole in combination with an echinocandine. For mucormycosis, there is no single recommendation for COVID-19 associated mucormycosis, but an overall recommendation for mucormycosis cases that can be applied. And this is the very nice paper published by several authors and headed by Oliver Corneli. For the first-line treatment, we should use liposomal amphotericin B, the very high dose, a strong recommendation for this treatment. And if there is renal impairment or pre-existing renal dysfunction, then we should use isobuconazole or posaconazole. And then it depends on the course of the disease or toxicity that might occur. In stable disease or in partial response and clinical improvement, there is a step-down possibility to isobuconazole orally or posaconazole orally using the delayed release tablet. If there is progressive disease during liposomal amphotericin B, then we should switch to isobuconazole intravenously or posaconazole intravenously or vice versa. If isobuconazole was the primary treatment or posaconazole was the primary treatment, then we have to switch to liposomal amphotericin B. Also, there might be renal toxicity, but due to the high mortality, you have to cope with also this renal toxicity. And in liposomal amphotericin B toxicity, there is a switch necessary to isobuconazole intravenously or posaconazole intravenously, or later on orally either isobuconazole or posaconazole. There's also a recommendation for COVID-19 associated mucormycosis in lower middle income countries where some of the azoles are not present, or maybe liposomal amphotericin B is not present. There's also the possibility to use amphotericin B, deoxycholate, but this is only for, as I mentioned, regions where the newer drugs are not available. Let me now mention some of the hepatobiliary side effects and the renal insufficiency or renal side effects that might occur during treatment with the azoles or liposomal amphotericin B. There's differences regarding different treatments, as there are higher rates of hepatobiliary side effects in voriconazole treated patients in comparison to isobuconazole. There is a not clear picture regarding the liposomal amphotericin B hepatobiliary side effects. The rate is 5 to 21% in the literature. And regarding the renal insufficiency, there is some data that voriconazole, regardless the mode of or the intravenous or oral administration, is present in 17 to up to 39% of patients. And this is not reported in isobuconazole treated patients. At the liposomal amphotericin B, there's a rate of approximately 11% up to 22% of renal toxicity in the literature. So be aware of these side effects when using some of the drugs in your ICU patients. Let me now move to the extracorporeal treatments. This is a case of invasive aspergillosis in a cardiac surgical patients treated with ECMO due to respiratory failure and invasive aspergillosis detected by lateral flow device and clinical factors and radiological factors. So we have also have to consider the extracorporeal treatment. And there is some literature, some case reports, and some in vitro studies that were done with antifungal drugs. As you can see here, for fluconazole, there's an in vitro simulation that gives us the information that fluconazole is not extracted by the ECMO circuit. So maybe fluconazole can use safely in ECMO patients, but on the ICU, we use for Candida infections echinocandins. And echinocandins, for example, caspofungin is also not sequestrated by the ECMO circuit. This is was detected in a case report, and there are conflicting results for liposomal amphotericin B. Some decrease or no decrease. It's conflicting in the literature, and there is one case of obstruction of the ECMO oxygenator. Voriconazole is decreased in patients treated with ECMO, so we cannot safely use voriconazole in patients with ECMO. And there's a recent paper addressing posaconazole in ECMO patients published from the Netherlands and from Belgium. And ECMO does not appear to influence posaconazole exposure. So a very, very interesting and a very, very helpful information that can be extracted from this paper. We did comparable results or comparable investigations on isobuconazole and received comparable results. So in our study, isobuconazole plasma concentrations, they are also not altered by the ECMO oxygenator. But of course, we need more research addressing the effect of ECMO on plasma concentration, because in the posaconazole study, there were 6 patients, and in the isobuconazole study, there were 7 patients. And this is the literature that we actually have. So we have to do more research on ECMO and other extracorporeal treatments, including renal replacement therapy in these patients treated with antifungals. There's also one very important point when we talk about different antifungals, that is the QTC interval, because voriconazole and posaconazole lead to a prolongation of the QTC interval. It's very important to also keep that in mind when we treat patients on the ICU or even outside the ICU with these drugs, because there may be an arrhythmia. Isobuconazole shortens the QTC interval, so this is different between the A source and in liposomal amphotericin B. Very important, it is an unaffected QTC interval. And therapeutic drug monitoring is recommended, it's mandatory in voriconazole treatment. In posaconazole, it's not recommended for the delayed release tablet, with the exception of graft versus host disease or other circumstances, maybe also for compliance reason, to test the compliance. And actually for ECMO, this was the recommendation that we could extract from the paper that I mentioned from the Belgium and the Netherlands. For isobuconazole, it's not clear right now where we need therapeutic drug monitoring, maybe also in ECMO patients, maybe in renal replacement treated patients. We do not actually know. It's also a question that has to be addressed in future studies. And for liposomal amphotericin B, there's no recommendation for therapeutic drug monitoring. Some slides to address the prevention of influenza-associated pulmonary aspergillosis and also COVID-19-associated pulmonary aspergillosis. One study unfortunately failed, and this was addressing influenza-associated pulmonary aspergillosis, also performed in Belgium and the Netherlands. The ICU mortality in patients suffering from invasive aspergillosis in influenza was very, very high, but unfortunately, it could not be prevented by administration of posaconazole. So this is still an open discussion if it is necessary to apply prophylaxis in influenza patients at the ICU. And in an observational CAPA study performed at our ICU, we could show that early antifungal prophylaxis at the ICU reduced the incidence of COVID-19 associated pulmonary aspergillosis from 70% to 1.4%, also using posaconazole. But this was an observational study and not a randomized study. This is my last slide. There are still open questions in CAPA and of course also in influenza-associated pulmonary aspergillosis, as we heard previously by Dr. Feys. There is no clear picture regarding the benefit of nebulized antifungals in influenza-associated tracheobronchitis, for example, and of course also in COVID-19-associated tracheobronchitis. There are 2 studies that showed that with nebulized antifungals we can prevent fungal infections at the ICU, mainly invasive aspergillosis. The role of liposomal amphotericin B in the ICU setting needs to be further elucidated, of course, and we need to address the point that some of the patients are treated with extracorporeal treatments, and this needs to be studied also, either ECMO or renal replacement therapy or both, because we do not know in a large a group of patients what antifungals are in this patient group. So we have to do more research on this topic. And with that, I would like to thank you and happy to take questions.
Thank you so much, Robert, for a wonderful presentation, and also thank you for bringing up the prevention and prophylaxis, because we received a number of questions actually relating to that and to the prophylaxis piece. And yeah, I think you outlined everything. Just as an add-on, so one of these studies you mentioned about liposomal amphotericin B, inhaled liposomal amphotericin B prophylaxis, was conducted in Spain in an ICU where they had actually a lot of environmental exposure to Aspergillus and very skyrocketing high kappa rates, and there it was also effective. So I think, you know, your conclusion is still valid. We don't have hard evidence. It's mostly single or non-controlled studies that show that there might be a benefit. But at the end, you have to go back to your individual institution. And if you're facing a situation like, you know, this ICU in Spain, for example, or for another reason have very high kappa rates, you might consider prophylaxis. Would you agree with that general statement, Robert? Or
yes, of course. I totally agree. It depends on the local epidemiology in the ICU. When you have an incidence of 2, 3, or 4%, that then you don't need a prophylaxis. Then it's wise to go for diagnostic approach to perform galactomana and beta-glucan, do cultures and do maybe CT scans when there is a persistent fever. But if there is a high incidence of aspergillosis, or if there is an outbreak, then it's maybe wise to do prophylaxis. But the mode of prophylaxis is not still clear. If you go for a systemic prophylaxis using posaconazole, for example, or a more local prophylaxis using inhaled nebulized antifungals with liposomal amphotericin B, or maybe both. Maybe it's good to do both. We don't know.
Very true, and it's also a field that is rapidly changing, right? With a number of new antifungals and new antifungal classes, new antifungal applications being on the market, probably, you know, in a few years. A lot of things will have changed.
Yeah.
And another question, Robert, I just want to bring up that came up in the beginning, but I thought was very appropriate to your talk, was the general question about caspofungin dosage in ICU patients. You talked a little bit about ECMO, but generally, what is your recommendation in terms of dosage of caspofungin?
I do not have a clear picture that I can present or that I can mention out from the literature, but there's the recommendation to use at least 70 milligrams of caspofungin when the weight of patients is higher than 80 kilograms. And most of the patients at our ICU are have a weight of more than 80 kilograms. I'm aware of some case reports where caspofungin is used up to 100 milligrams or even higher, but I'm not aware of any clinical study that shows benefit of these higher dosages. So we don't know. Maybe we also have to do more research on this topic. I do not have a clear answer to this question. But we usually use 70 milligrams per day and do not go down to 50 milligrams starting on day 2.
Yeah, so that's in normal weight, and I think it's also very valuable, response that, in more heavy patients above 80 kilograms, we should kind of like stay probably with 70 milligrams and choose the higher dosage. That's great. Thanks, Robert.
Yeah, maybe I can mention one clinical entity that is also very important in the ICU, and this is the septic cholestasis, for example. Even if patients do not have fungal infection, there's maybe due to the septic cholestasis an invasion of Candida up to the biliary tract to the liver, and then liver infections by fungi might occur. And this hepatobiliary side effect or disease maybe also leads to a lower secretion of caspofungin into the hepatobiliary tract, and maybe there is then a lower activity in the biliary tract, and this is also a reason to increase the dosage. So in these cases, when there is a high bilirubin level, we sometimes increase caspofungin or even other echinocandins, anidulafungin, for example, to prevent or to treat this kind of disease in the hepatobiliary tract.
Fantastic. Thanks so much. Volkan, do you have more questions?
Thank you very much for a very nice overview of this complicated topic. I still wonder about differences between the centers, and there's also a question about that. Is it due to diagnostics or sampling or tools or the environment, or what are your thoughts about that?
I believe all of the reasons that you mentioned, because these studies were done in the very early beginning of the COVID-19 pandemic and in the early beginning of the awareness of COVID-19 associated invasive fungal infections, and everyone was using a slightly different diagnostic tool. Some were using galactomannan out from the BAL sample, some from the serum. So the definitions were not the same, and this was a problem. And therefore, I'm very happy that Philipp Köhler presented then a paper where a basis were published for future studies, where we can now compare the rates of invasive fungal infections throughout different ICUs in Europe or worldwide. So this helps a lot.
Thank you very much. And another question about the colonization index. Do you perform that in your center?
No, we do not. We did that in the past, and we also performed studies, but we do not do that anymore because it's time consuming. The cultures are coming late, and we perform biomarkers instead of the colonization index with a very fast turnaround time for beta-D glucan, for example. We receive the results within 1 day, so very, very fast, and we can use this for the guidance of antifungals on the ICU, especially for Candida infections.
Thank you very much.
So there's one more question that is, I think, super tricky, but maybe you have an idea. I personally don't know how to answer this or are not aware of any literature, but this is about COVID-19 associated with a fungal infection and how this fungal infection may impact the transmissibility of the virus. I guess, beyond some logical thoughts, but what are your thoughts? Any idea, Robert?
No, I don't know. I don't know the literature addressing this question, but it's a very interesting question. I don't know.
I think it's interesting, yeah. And I mean, I think the general recommendations definitely, you know, even in patients that develop COVID-associated fungal infections, is not to discontinue the dexamethasone because of the fungal infections. I think that's important to emphasize. We should continue treatment of underlying COVID as recommended in guidelines and not modify the treatment for COVID due to the fungal infection. I think that's an important message there. But whether how the CT values develop with the fungal infections, and whether it's due to coughing or whatever when patients are discharged. I mean, mostly these infections, especially Aspergillosis, happen in the ICU, but of course mucormycosis sometimes also happens after ICU discharge, you know, which could at least, but then again, you know, when looking at mucormycosis worldwide, it's mostly, and the one that's happening after discharge is mostly reno-orbitocerebral mucormycosis and less the pulmonary form. Again, having implications on the symptoms. So I think interesting question, but we just don't have the answer probably. So I think, I'm not sure, Volkan, do you have more questions? We're also nearing the end of the webinar, but if you have one more urgent or...
No, I don't have any more questions.
Perfect.
Thank you very much.
Okay. So then with that, I will just share my screen for the concluding slides, but while I do that, I already want to thank the speakers, first of all, I mean, for their really outstanding presentations and for really a very interesting webinar, also for me to chair and listen to the talks. Thanks so much for, you know, all the time in preparing these presentations and all for giving excellent talks today. Also, thanks to my co-chair, of course, Volkan, for guiding together with me through this session. And last but not least, thanks to you, the audience, for all your interesting questions and discussions that were also, I think, very enlightening for both us, the chairs, and probably the speakers. And with that, this really brings me to the conclusions of this third ECMM Healthbook webinar. The fourth and last one of this series will be end of November, so keep an eye open for that one. You will again see advertisement via the ECMM and also via Healthbook. And last but not least, of course, we want to thank the organizers, want to thank ECMM and Healthbook and also the sponsors, mentioning here particularly Gilead Sciences, and wishing you all a great evening if you're in Europe, or a great day or a great night wherever you are in the world. Thank you so much for your attention.